Hi, my name is Chris Puri, and I appreciate you watching this program for the Tennessee Bar Association Health Law Forum. Today, we are going to be talking about COVID-19 and how it has impacted the long-term care sector of the healthcare industry. So just as an overview and an introduction, I'll tell you a little bit about myself. I have been practicing lawyer for about 20 years. And in that time, most of my practice has been in the post-acute and long-term care space for providers in those spaces. Throughout the majority of that time, I have also been outside counsel for the Tennessee Healthcare Association, which is the organization representing the largest group of nursing home and assisted living providers here in Tennessee. In my role as counsel to the association, I work very closely with staff of the association, as well as agencies like the Department of Health on those issues. As you can imagine, the unprecedented situation with COVID has offered many opportunities over the last 6 or 7 months to work on regulatory and policy issues related to COVID. And what I'm going to try and do is essentially walk you through a lot of the things that have happened over this last 6 or 7 months and talk about them and how they have affected facilities. And then also at the end, talk a little bit about where we might be going. So just to set the stage as an overview, we're going to start out, give you a little overview of the situation at the outset of COVID relative to what Tennessee's long-term care landscape looked like. We'll talk a little bit about sort of the initial federal and state waivers that were provided at the outset of the COVID situation. And then also discuss and briefly the federal provider relief funding. There is another session on that, so I'm not going to go into a lot of depth, but it's important for you to know how some of the resources that have been dedicated to providers and COVID come into play here. We'll talk about some data reporting, some new data reporting requirements for long-term care facilities, and then move into two really important and difficult issues for long-term care facilities, that being testing, both of residents and staff, and how that has developed over the last few months. And then also talk about closing and visitation, and then how the state and CMS have handled the reopening of facilities, which has been a challenging issue. We'll also talk about the interaction on the post-acute side between long-term care facilities and hospitals, and how the situation with COVID has changed the dynamic of how facilities are admitting and cohorting and organizing their facilities and the residents within them. I'll give you a quick update on some federal and state task forces on long-term care. And then, as I said, I'll try and wrap up with some considerations as to where exactly we may be going and what it will look like in whatever a post-COVID world will be. So just setting the stage. So Tennessee's long-term care providers, you can see on the slide, we have 319 licensed nursing homes representing almost 37,000 beds. We have a few more assisted living providers representing about 22,000 beds. So those facilities are generally average a little smaller than nursing homes. We have 53 homes for the aged with about a little over 1,000 beds. And then between home health and hospice, about 427 providers, including branches. So that sort of sets the stage of what we're talking about in terms of providers. In terms of COVID and where we are, these are numbers that were pulled today from the Tennessee Department of Health. You'd see about 200,000 cases, just under 2,600 deaths. Those numbers are total for all of Tennessee. You will see also there in the slide the long-term care facility numbers currently. Facilities with over one COVID case currently, and that is an active COVID case. That would be a situation where a resident or staff member has COVID, has not recovered or gone through a period of time where they are no longer contagious. So that would be about 437 facilities. We have a little over 5,000 resident COVID cases and then staff cases a little bit lower than that, about 4,500. And resident COVID deaths, quite unfortunately, we have 721 resident COVID deaths in long-term care facilities. There's never any positive news about deaths from COVID, but I will note for you all that Tennessee overall has been very good in terms of its comparison with other states relative to the percentage and the number of deaths in long-term care facilities for COVID. Tennessee actually ranks very good on that, which is just good, although we certainly don't like to dwell on deaths that happen. This slide also then provides you a little bit of what the COVID impact has been on nursing homes using occupancy as a measure. You can see the numbers there. These numbers are taken from data that the Tennessee Healthcare Association collects during the COVID period on a monthly basis. This represents almost all of the facilities. There are a few facilities that may not be included in the sample on a given time. But as you can see, the numbers there, the net occupancy drop is about a 7% drop, and then a total patient drop of about 2,500 patients overall, which given the average number of total patients is about a 10% drop. When we talk a little bit later about where we're going, that 10% drop is probably a pretty steady number that we're seeing nationwide in terms of reporting. So let's talk a little bit about waivers, state and federal waivers. At the outset of the public health emergency, the president declared an emergency, and the Secretary of HHS granted several blanket waivers to all types of facilities. The federal Health and Human Services waivers that were effective on March 1st, the ones that are most relevant to long-term care facilities are the ones that are listed here. Those waivers are dependent upon the declaration of a public health emergency, and that public health emergency was recently continued in the last few days until January of 2021. So these waivers will continue. And these waivers are designed to provide flexibilities for facilities operating within COVID. The one that sticks out probably is very important is the waiver of the 3-day prior hospitalization. For Medicare coverage, generally a 3-day prior hospitalization is required for coverage. During COVID, that is waived. And that has been an important feature for facilities in terms of making sure that they can provide skilled care to patients coming in from hospitals and acute care settings. There have been some waivers of record keeping requirements. Also, there are waivers of transfers, discharge regulations, as well as grouping of COVID patients, and an allowance of nursing homes to be set up in terms of dedicated COVID units, sort of without walls. Those waivers of traditional protections on transfer and discharge are limited to COVID situations and are designed to allow the cohorting of patients within a facility. We'll talk a little bit about that a little bit later on. There have been also some significant waivers of physician involvement in the facility. There has been a relaxation of the ability of physicians to delegate tasks within the skilled nursing facility and make visits to the skilled nursing facility, including the allowance of the use of telehealth visits as well as advanced practice nursing, nurse practitioner visits in there. And then also an important one for staffing purposes has been the waiver and allowance for CMS to allow training and certification of nurse aides and feeding assistants. Normally, in a normal situation, not related to COVID without a waiver, no one can work in a long-term care facility for more than 4 months without being in a nurse aid program. CMS, in conjunction with some of the national associations, worked to develop a program allowing individuals to come into long-term care without having to go through that nurse aid training program, as long as they went through a brief course explaining the necessary skills. And that has been a significant help to facilities because as we talk about nursing homes and long-term care facilities, other long-term care facilities have been doing very hard by staffing issues because of the positive tests of staff and the need for those individuals to be out of work based upon the CDC return to work criteria. Also, there have been state waivers. The acronym there, BLHCF, stands for the Board for Licensing Healthcare Facilities, which I think many of you are familiar with. The Board for Licensing Healthcare Facilities is the regulatory body, along with the Department of Health, that provides licensure of healthcare facilities and other types of healthcare providers. In March, the board met and approved policy memorandum number 82 and included a whole host of waivers for different types of facilities, long-term care facilities, but also hospitals as well, and other providers. Those waivers have been revised and renewed in April and then also in September. The current policy number 82 remains in effect until October 7th, and it is expected that those waivers will be extended at the October board meeting to the February board meeting or the end of the public health emergency. The full policy memo begins on page 58 at the web link that is in the slides, and you can certainly look at the content there. I will note for you all that there are materials to this program, including the slides, and in many relevant points, you will see underlined text that does link to a relevant document that's being discussed, as well as some handouts that are associated with the program. I want to take a quick turn and talk about federal provider relief funding. You all as practicing healthcare lawyers know that one of the things that COVID has done is create tremendous resource challenges for all healthcare providers and all healthcare facilities. The federal government has stepped in the healthcare area, just as it has in many other areas, to provide certain types of stimulus funding for providers. And just a quick summary of those. One of the main initial right off the bat aspects was that HHS CMS provided advanced accelerated funding for providers. Essentially, this was money that the provider would otherwise earn from reimbursements from Medicare and Medicaid, but was paid in advance to help the initial cash flow situations for providers. CMS recently announced a delayed payback for 1 year for those funds, and those payback can stretch over 29 months. Given the cash flow situations for long-term care facilities, that's certainly been a welcome change. As you can see, there are phase 1, 2, and 3 tranches of funding that associate with different types of providers. Medicare providers, Medicaid providers, assisted living facilities were also included in phases of the tranches, and then also a targeted distribution to skilled nursing facilities and assisted living, largely to try and cover and defray the initial and increased and ongoing costs of PPE testing, supplies, those types of things associated with the COVID crisis. Phase 3 was just announced, and that is an application pool of funding, and it's designed to largely clean up any providers who did not receive either their full funding from the other tranches, or also to address situations where providers have had abnormal losses because of COVID. Shifting to data reporting. One of the things that happened as we developed in COVID, and now we're looking at a situation where this is a couple months into the COVID situation. If you sort of mark March as the beginning of largely the pandemic, sometime in February, we're now in April and May. And CMS was getting a lot of comments that the reporting of cases and deaths in nursing homes were not being accurately and consistently reported to CMS, and there wasn't a way of tracking all of these. CMS and actually CDC have a data source and a tracking network called the NHSN for short, the National Health Safety Network. And the NHSN network is something that largely long-term care providers have not used by and large. However, as noted on the slide, CMS enacted an interim final rule on NHSN reporting in May 1st. And that rule required long-term care facilities, specifically skilled nursing facilities, to report COVID cases on a weekly basis so that it would strengthen CMS's surveillance locally and nationally of the COVID situation and help to get assistance to nursing homes faster when there was a situation of an outbreak or multiple cases or those types of things. The rule requires reporting of cases, clusters, testing, census, and also staffing and supplies. And actually CMS has had iterations of additional reporting elements that have been added to the NHSN portal. I think overall what we're looking at here is there's a desire, since the NHSN portal with CDC is connected to other types of providers, to work on having a single portal, a single data source, a single set of databases where public health activities can be done from, so that essentially throughout a continuum of care, everyone is on the same page and reporting in the same way. The rule also, besides data reporting to CMS, required new reporting of cases to residents, families, and their representatives. That was largely being done, but CMS did enact a requirement that be done in all cases, and that reporting has to be done by the next business day, so that there's prompt notification and transparency by facilities to its residents and families. Like I said, there's new integration of databases. CMS also recently announced the opportunity for skilled nursing facilities to get what's called level 3 access. Right now, that is a voluntary situation, it's not an obligation. The level 3 access provides additional ability to report and get reports from the system. And there certainly are a lot of opportunities here. However, there certainly has been commentary in the trade press and otherwise that when you have data, you also have potential for enforcement actions. And at least one lawyer at a conference has made the comment that perhaps we have the perfect storm for more Department of Justice targeting of facilities with the poor data profile. We will see, but certainly enforcement risk is something that facilities are thinking about as we look at this. Additionally, the challenges of NHSN have been getting registered and those types of things in a very short period of time, which facilities had to do and caused, frankly, a little bit of delay in the rule because there was a backlog in getting credentials and those types of things. Okay, let's talk a little bit about COVID testing. A very important area and one of the sentinel aspects for making sure that we prevent cases in long-term care facilities. So as we moved through March and April, we, as I said, had a reporting obligation that was enacted by CMS. And then Tennessee took the somewhat unprecedented leadership step to require testing of all residents and staff at facilities. As you see, Governor Lee issued Executive Order 38 close to the end of May, on May 22nd. And that order said that facilities are strongly urged to test all residents and staff across the state. Very importantly, the state offered financial and operational support for that testing. And certainly Governor Lee and the Department of Health certainly deserve credit for working very closely with industry providers to make sure that these important safeguards got enacted. The state funded the initial testing of all nursing homes and assisted care living facilities, and then also funded ongoing testing. As you see on the slide, shortly thereafter, the Board for Licensing Healthcare Facilities adopted an emergency rule. That emergency rule required baseline testing of staff and residents in all long-term care facilities. And it also, as I said, required weekly testing of staff in nursing homes, not residents, but staff. The Department of Health was certainly managing situations where cases were reported in nursing homes and there was testing of residents based upon its public health function. As you might imagine, anytime things are done fairly quickly, there were significant gaps in guidance in interpretations. There are multiple frequently asked questions, sub-regulatory guidance on the rule that have been done between the industry and the Department of Health. So that's sort of where we were sort of at the end of May, going on until pretty much the end of this month. And in September, CMS gave indications that it was going to issue a federal rule. States largely had adopted different testing regimes. Many of them were different, some were the same. Tennessee required weekly testing, some states required bi-weekly testing, some states required every other week. It was really all over the board. And CMS determined that they wanted to establish a federal testing requirement for all skilled nursing facilities. So what happened was that on August 25th, CMS enacted an interim final rule, established a new Medicare requirement for skilled nursing facilities, that COVID testing must be done of all residents and staff. It's a new regulation at 483.80H on COVID testing. And accompanying that was sub-regulatory guidance of QSO 2038. Those QSO numbers you'll see referenced in the presentation deal with CMS memos that were issued that are, as I said, sub-regulatory guidance. They're all available on CMS's website, and most of them are linked throughout the presentation slides or in the handouts. Let me go back a second, I'm sorry. So as that was occurring, the Board for Licensing Healthcare Facilities and the Department of Health were having discussions with the association and the industry because it was clear that there were going to be multiple rules that facilities were going to have to follow. If we were to establish a new federal standard, then also we're going to be looking at a state standard that might in some ways conflict. And there wasn't much guidance until the rule was actually put out with the QSO memo. So what the board did was to actually approve the repeal of the state testing rule effective October 1st. That was done on September 8th with a delayed effective date. The CMS testing rule, the QSO memo, was implemented with an effective date of September 4th. And there were 3 different types of testing requirements. Symptomatic testing, so testing a resident or staff member whenever there were symptoms. Outbreak testing, which would be whenever there was a new case of COVID identified, either in staff or residents. And that outbreak testing required testing of both staff and residents every 3 to 7 days, which was then is required to be repeated until there are no new cases for at least 14 days. So a pretty significant testing regime requirement there. And then also significant was routine testing of all staff that was based on a county positivity rate. The county positivity rate requirement and indicator is not in the rule. It's referenced by the sub-regulatory guidance in the QSO memo. And based upon your county positivity rate, you either test once a week, twice a week, or once a month. Twice a week is over 10%, once a week is 5 to 10%, and once a month is under 5%. And as I said, the sub-regulatory memo covers much of the requirements. There have been a lot of challenges, and there certainly are some discussion points around the testing. One of them has been access. Obviously, long-term care facilities, like other facilities and other providers and other businesses, face problems with lack of access to testing supplies, testing kits, testing machines, in some cases of PCR testing labs to do the testing. So there was certainly initially a bit of a difficult situation to get that worked out. Early on, especially as testing ramped up across the country and we had more and more cases, there were significant delays in PCR testing. PCR testing is the first, if you will, type of testing that was largely done on COVID. It's the swab that goes deep in your nose and is then sent to a lab. It's seen as probably, I think, the more or most reliable of those testing modalities. But obviously, there's a lot of debate going on because delays in the testing resulted in significantly less surveillance, especially in high-risk populations like long-term care facilities, skilled nursing facilities, assisted living. Ideally, from public health authorities, they would say a 48-hour turnaround is sort of the gold standard on that. In some cases, that was stretching out to 7 days or more, resulting in real problems with using testing as an offensive measure to prevent the spread of a disease within a facility. We have had a lot of challenges with differing modalities. This is not unexpected, and in some cases is probably a good thing as technology very rapidly develops in this area. Early on, PCR testing was the only FDA-approved testing, and then we developed point-of-care testing, and now we have they're called the Abbott Binax cards. These are all different types of testing. CMS has actually sent a point-of-care testing machine with supplies to all facilities, all skilled nursing facilities that have a CLIA waiver. And that has certainly been helpful. Obviously, still have supply chain problems and those types of things. But some of the test use also is off-label from the FDA Emergency Use Authorization. And the other issue with some of the testing is there have been concerns as we develop these testing and approve them through use, some concerns about the accuracy, both positively and negatively about testing. It has been challenging for facilities to continue to test their staff members and employees on a weekly or bi-weekly basis, especially the PCR testing. It challenges facilities in terms of maintaining staff because people just don't like to have a swab stuck up their nose on a regular basis. And then also, because the testing is frequent, there certainly are positive cases that occur in communities that have a high incidence of COVID. And because of the return to work criteria, those individuals are out of work. So backup staffing has been especially difficult for sole operators. Resources and cost of testing has been a challenge. Tennessee has been lucky in having a state that covered testing for a very long period of time. With the implementation of the federal rule, the state has ceased direct reimbursement of the cost of the test, but is still working with providers to try and find ways to identify supplies and those types of things for them to do it. But that certainly is challenging and will continue to be challenging depending on how long, obviously, we are looking at a testing regime that is so frequent. Testing also, in addition to costs, requires a significant amount of staff time. In a typical facility, you may be looking at anywhere from 50 to 100 employees, and depending on the size of the facility, an equal number of residents. And just the actual time to complete the testing and report and those types of things takes time. Facilities have learned also that the tests that are facility-based, the point-of-care testing, the Binax cards, they have an obligation to report under the CARES Act and CLIA, so that's been a new opportunity for facilities that has been challenging. And lastly, there have been challenges because the rule, as I noted, if you noted the word staff was in quotes, staff includes individuals beyond employees. It includes contractors and those doing direct care in the facility under the CMS rule. So it would include volunteers. That can be difficult because obviously the facility isn't in control of the schedules of those individuals, but still nonetheless has an obligation to get them tested. Okay, let's move on and talk about what's been a really challenging and difficult issue for facilities and those working in, and is closing and visitation. See where we got. So again, with the onset of the COVID crisis, okay, in March, we had CMS take action to close visitation activities. Our normal situation prior to COVID is that federal and state regulations do provide situations and a setup for residents to receive visitors. And in fact, is a right of residents to receive visitors. However, because of the pandemic, as with many other folks, certain aspects of our normal life were restricted and modified. CMS in QSO 2014, that was initially issued on March 4th and revised on March 13th, said that for all facilities nationwide, the facilities should restrict visitation of all visitors and non-essential healthcare personnel, except for what were referred to as compassionate care situations, such as end of life. These would clearly be hospice situations and those types of things, and a little bit broader than that, situations where it, for the emotional health of the individual and someone who is integrally involved in the care of that individual, there should be an exception to that. So that was put in place. In addition, the non-essential healthcare personnel applied to those individuals like barbers and hairstylists and those types of things. It would normally come into the facility. You saw facilities adopt policies where by delivery people would not come in the building and those types of things. Around the same time, on the state level, Governor Lee issued Executive Order 17 on the 22nd of March, and then directed that persons in the state of Tennessee should not visit nursing homes, retirement homes, long-term care, or assisted living facilities. And the reason for that was obviously to try and prevent the risk of transmission of that disease from the community into the facility. And again, remember, it's interesting when you look back at this crisis, but remember we're talking about March of 2020, and we're trying to figure out some of the science about how this disease is spread. So CMS took the action to close facilities altogether. That situation continued in Tennessee, particularly, until June of 2020. And a couple of things happened. At the federal level, CMS issued a QSO memo 2030 on the 18th of May. This memo incorporated for CMS largely much of the White House reopening guidance. The White House issued a separate reopening guidance document, and the QSO memo takes that document and incorporates that for the reopening of healthcare facilities, including nursing homes. Also, you had issuance of Executive Order 49 and Tennessee Health Department guidance, and they released guidance on requirements and options that permitted limited visitation while still trying to keep resident populations safe. This reopening guidance that was issued in June was based upon two things, the two gating criteria, if you will, which is a word we come to use. One is that a facility needed to have no cases, no new cases. And there also needed to be an overall stability of the disease burden in the community where they were located. So that metric was set as the average cases over 14 days. And I can tell you that facilities, myself and myself included, track those data on a daily basis that were posted by the Department of Health. Unfortunately, what happened is that we quickly developed a situation where, because of the case incident around Tennessee, as the disease evolved through June and July, we hit a situation where all 95 counties were above that threshold, that disease burden, and therefore closed to visitation by August 1st. So we were in a situation where, while limited visitation was in fact allowed, the gating criteria was shutting it off overall, largely for everyone. So we fast forward to September, and as I said, this is a difficult issue, and it really is because we were now looking at a situation of 6 months or so where facilities had not been allowing visitors, not been allowing group activities, not been allowing beauticians, those types of things. There was a lot of concern on the part of residents, advocacy community, the public at large, legislators, about how we were going to deal with this, because we unfortunately were sort of in an impossible situation, probably both ways. Certainly the desire to keep everyone safe was primary, but at the same time were significant psychosocial effects of not seeing loved ones on a regular basis, as residents had done. So two things happened, one on the state level and one on the federal level. And they happened on the same day. They happened on the 17th of September. The Department of Health, after working closely with industry and a lot of stakeholders, issued two guidance documents, one dealing with visitation and one dealing with activities and dining. And these apply to all long-term care facilities as guidelines. These were largely based upon reopening criteria that had been worked on back in June. The gating criteria changed. The gating criteria were two for visitation: a 14-day situation where the facility was case-free, and a 28-day situation where the facility was case-free. There was no longer a county rate that was involved in the gating criteria. The new guidance that became effective on the 1st of October allows outdoor and limited indoor visitation in the 14-day situation. And after 28 days allows more extensive inside visitation under what's called an essential caregiver model. This is a model of visitation that a lot of states have adopted. This guidance for activities also resumes resident activities within the facility if there have been no new cases in 14 days, and allows the return of barbers, beauticians, group activities, dining. The Department of Health has a weekly long-term care update call, and I can tell you from being on those calls that the question about when barbers and beauticians were going to be allowed back in facilities was asked routinely on every call for probably 5 weeks. So I think in some ways the guidance was welcomed by everyone to put a certain situation to rest. That night, so that was released on the afternoon, and that night CMS released QSO 2039, which provided new guidance at the federal level, revising that memo I mentioned at the outset of our discussion of this section that closed off visitation. As you can see, I quoted from the memo in terms of CMS's rationale about resuming visitation. The guidance provides preference for outdoor visitation, but also does require indoor visitation be supported. There are aspects within the memo that a facility can use to limit visitation in certain ways, but it has to be a reasonable clinical or safety cause consistent with the regulation there cited at 4310 on visitation. We certainly, since this is new, there hasn't been any enforcement of this, and there are a lot of questions around how the implementation of this will actually occur, because facilities now have a situation where they allow visitation, which I think was welcome. But I think one thing that probably could have been improved in the guidance, at least on CMS's side, is going from a situation where we were in March, where all facilities were closed, to now we are in September, where there's very little that's closed about the facility. I think a graduated approach might have been more welcome and maybe, in my opinion, made more sense. One of the things too that has gone on during this situation is that we still had situations of discharges from hospitals. And early in the pandemic, Tennessee saw the experience of the Northeast, where we had hospital capacity overload and some serious public health issues with mandated nursing home admissions from hospitals of COVID positive residents. And I think the state overall, Department of Health, the Tennessee Healthcare Association, as well as Tennessee Hospital Association, were very proactive in engaging in discussions around what post-acute transition protocols look like, particularly around how to use testing as a tool to prevent the infection in long-term care facilities. There was a situation where CDC guidance was quickly changing here relative to the use of testing, and at one point it was true negative tests, and then it moved away from that. We've now moved to away from testing as the gold stone and more to a symptomatic approach to screening people and those types of things. So there was definitely a tension between facilities' desire to make sure that individuals were coming in who were COVID negative and not COVID positive, or at least knowing their status. And then also a desire on the part of hospitals to want to make sure that sufficient hospital space was available. Tennessee was lucky, but obviously we certainly had an increase in hospital admissions and hospital capacity. Right now, those numbers look pretty good. There was no statewide protocol that was developed, but certainly I know from representing the association and clients, there are a lot of discussions at the facility level, both between hospitals, health systems, and nursing homes and assisted livings, about how to apply this and what made sense, both from the aspect of protecting individuals, but balancing the need for hospitals to have a flow of discharges and admissions to long-term care facilities. I put this slide on here just to give you a little bit of sense of sort of how the typical situation of facility has changed pre-COVID. Largely, again, this is typical, this is in every facility, but your cohorting of residents, your grouping of residents would largely be around particular functional needs. Skilled residents would, usually Medicare would be serviced in one section or wing of the facility. Long stay residents would usually be grouped. You also could have different units for ventilator patients, dialysis. We did have limited number of ventilator units in Tennessee in skilled nursing facilities, but increasingly use of dialysis and dementia behavior units. What developed largely as CDC guides developed, and to an aspect of protecting the incoming admission, being able to take admissions by still providing sufficient protection for those in the facility, was you sort of developed a three-tiered situation for a lot of facilities, if not most facilities, where individuals who were definitely negative, either had it, recovered, had been in the facility, not been out of facility, or were long stay patients, were tested negative, they were in a certain section. Similarly, then you had individuals who were positive, might have been admitted as a positive patient, that were cohorted into a positive either wing or section of the facility that was physically separated, or in some cases, some facility as isolation units. And then obviously you had a middle category of undetermined of those individuals, were new hospitalizations, those types of things where you didn't know status. Maybe you were waiting on a test, and those individuals were categorized as well. I put at the bottom, there was a limited effort by TNCure and the Department of Health to contract with certain dedicated COVID facilities. I'm going to show there are about 8 of those facilities overall. But one of the challenges that I put on here is that it's difficult to dedicate a COVID unit as a whole facility because there was a lot of questions about what exactly the planning was for volume. As I said, we didn't experience the surges that some other states experienced, and therefore there was a little bit of a chicken egg situation with some of those facilities, but we do have some that are operating under a contract with the state. Like I said, facilities struggled with testing, but also with PPE to protect staff and residents. I would say the PPE, personal protective equipment situation, has certainly improved, but obviously still has resulted in significant costs, as it has for many healthcare providers. I want to quickly mention, real quick, 2 federal task forces, and then let's sort of look forward a little bit. In any big crisis situation, there's certainly a desire and opportunity to study and learn lessons about what's going on, and that has happened at both the federal and state level. The White House, through HHS, formed the Coronavirus Commission for Safety and Quality in Nursing Homes. They were formed on April 30th and then came out with a report on September 4th. They had 4 objectives, largely maximizing best practices, learning from lessons about how to prevent COVID, those types of things. It had a broad representation of 25 individuals across industry, advocacy communities, academia, medicine. They issued a 186-page report with 27 principal recommendations, and I've given you the link to the report that's done by MITRE, who was the contractor with CMS. And I will say CMS asked the group to focus on recommendations that could be within CMS's authority and delivered immediately within 6 months of the report. So it was designed to be an actionable report. There are significant recommendations in the report. As I said, 27 principal recommendations. Many of them have broad consensus, some do not. I commend that to you as sort of as something to look at, because it's an interesting analysis. Also, as you would expect, and you all are aware, there's been a tremendous amount of politics around the coronavirus situation. Representative Clyburn from South Carolina has chaired the Select Subcommittee on the Coronavirus Crisis. This has looked at the coronavirus response of the federal government overall, but one component of that was started in June of 2020, the committee wrote to 6 private nursing home companies. 2 of them were publicly held, seeking significant amounts of production of data. Our firm is representing one of those 6 companies, and I have not been directly involved day to day, but I can tell you that it's been a voluminous amount of information when you are part of a congressional investigation, and that is an ongoing inquiry. Tennessee also put together a task force. It's been chaired by the Department of Health, Assistant Commissioner Brent Culberson, and Patient Advocate Sally Pitt. This includes representation across the spectrum as well, of providers, families, advocates, government. They had their first meeting on September 29th, short, mostly organizational meeting. But out of the meeting, there were some priorities of work that developed. There certainly is desire to look at how the support of ongoing testing occurs for long-term care facilities. There is interest in looking at staffing and the delivery of care within those facilities, making sure that facilities are able to provide adequate staff to take care of residents, especially in the situation where their staffing is impacted by the COVID situation. There is some look at visitation and making sure that we are correctly hitting the right mark in terms of balancing the need for visits with the safety of residents overall, as well as mental health, and then looking at sort of transitions of care, as I mentioned, similar to the issues I've talked about before, relative to how we look at people moving through the post-acute continuum overall. So let's talk a little bit about moving ahead. Certainly one of the challenges is visitation and safe openings. As I said, really an impossible challenge is starting visitation while transmission is so high. And it's been extremely difficult for facilities to manage those expectations. But it's been an equally impossible situation of continuing to have closed facilities indefinitely. What assisted living facilities have also realized is that there's really a necessity to get back to normal move-in behavior to assisted living, and also getting back to normal discharges to long-term care, to nursing homes. I think there's also a lot to look ahead on this issue of post-acute transitions. We really need a better understanding of the transmission risks and how the role of testing works. There certainly has been a quick evolution here. As I said, we've gone to different modalities of testing. We've gone from ones that might take 7 days to come back to ones that might take 7 minutes to come back. Not all of those are widely available. So how we deploy those, how we use those, and how we understand the need to test individuals prior to a transition from one facility to another, especially when that individual is going to a congregate environment, is something that I think definitely will be an area of work across the post-acute and acute spectrum. I showed you the sort of rudimentary diagram. I think also we're going to be looking at how we re-engineer for facilities for what may be routine isolation and cohorting. You know, it's challenging because a long-term care facility, a skilled nursing facility, definitely an assisted living facility, is designed to really do 2 things. It's designed to provide healthcare, but it's also designed to be a home for an individual. So the question becomes, how do you essentially, you know, have it be someone's home, but then also be able to isolate someone or protect them from other residents or protect other residents from them. So certainly some things are going to be looked at. There has been some preliminary data from a group called the Greenhouse Project. Greenhouses are a type of nursing home that has pods, 8 to 10 unit pods to make up the whole 100 or 80 beds or however many beds. There has been some limited data that they have had some experience, a better experience in terms of keeping the virus at bay and those types of things. That being said, there are also studies that say the most relevant factor has nothing to do with the quality of the facility. It has to do with the rate of transmission in the community. So that's certainly something that is going to have to be factored in how we deal with that. There's probably a need for a standardization of protocols, and likely that I would anticipate that's going to happen, though, largely through individual relationships with health facilities, health systems, and long-term care facilities, because certainly those have happened. Those have been happening for a while. I think that in certain given situations, the COVID situation has probably accelerated the integration and the working together of long-term care facilities and health systems. Probably the opposite as well in certain situations, but I think there certainly has been a recognition by everyone that we all need to work together to protect a population that's very vulnerable. And then also, as I said, there's a lot of new data. So does integration of NHSN open opportunities either for public health activities or for functions between health systems across the post-acute spectrum? Probably to be seen. I didn't talk a lot about telehealth, but I did talk about the waivers. And clearly one of the things is that COVID has highlighted a critical need for the involvement and leadership of strong physicians and medical directors. Those facilities that have done well through that strong leadership with physician involvement, because this is such a difficult situation of a challenging disease that we don't know much about, that has required the digestion, if you will, of massive amounts of medical information, as well as the management of individuals, sometimes with COVID, who present complex and sometimes rapidly changing symptoms. So telehealth has been a godsend, if you will, in the long-term care spectrum. That was also a trend that was accelerating, but has really accelerated as it has in all other sectors of healthcare. But I think it's going to certainly be used to manage better care within the facility, and also to help manage complex patients, to provide that access to learned individuals who might not otherwise be at the bedside 24/7, but are there and can be there through a virtual means. Then largely, not to be negative, but I mean, I think clearly there are some issues about how competition and viability play out. I've quoted some articles from Skilled Nursing News, a trade publication, and you know, I talked about the Provider Relief Fund. I talked about the resources throughout. Everyone is doing their best, and there are tremendous resources that are needed, not just in healthcare but overall. So one of the issues becomes not only resources but the cash flow. When do revenues and when do expenses match with each other? You see the reference there to Sabra, a real estate investment trust, looking at write-offs for some of their operators because some concerns about them being a going concern. That may be a little bit premature, but obviously there are some warning signs out there to make sure that we don't have a situation of a mass bankruptcy that we had before. I don't think that's where we are. I think that the support from states and federal governments has been enough to keep that from happening. But clearly from a sort of macroeconomic and finance situation, they're trying to be looked at. As I said, occupancy, flow, and lag is important, both for skilled nursing facilities and assisted living. There have been multiple public reports of almost a 10% census drop overall in skilled nursing facilities. While hospitals largely had a similar impact with the cessation of elective surgeries, largely I think that has come back in a bit of a V-shaped curve on a sharp return. But the return for skilled nursing facilities, particularly because some of these issues of closure and those types of things, has been less so. On the assisted living facility side, obviously move-ins are a key aspect of assisted livings. What one operator has said to me is that you have to remember that, when people aren't moving in now, largely because they'd rather stay home and not be in a congregate environment, concerns about the spread. But that wave of individuals takes a while to come back. So you see the statistic about the drop to a record low, that NIC is the National Investment Center that keeps a lot of long-term care facility statistics. So that's something to keep an eye on as well. One of the other concerns is, we as a country have funded a lot and spent a lot of money. Do we have a Medicaid funding crisis, in the out years of this, because eventually bills come due and we have to figure that out. Medicaid is still a large driver of funding for skilled nursing facilities, so that's a concern. Enforcement is always a concern for long-term care providers. We have not had regular surveys because of the concerns about individuals going into facilities. So what all this looks like when we open back up, and whether some of the goodwill that has been generated with everybody working together, government and providers and those types of things, hopefully that continues. I certainly hope it does. I think we certainly have optimism that's going to continue here in our state, but that's always a concern. And you certainly have situations of providers that do the wrong thing, and that enforcement may be necessary. And then lastly, I think that kind of put competition. There certainly have been trade press articles about whether or not there's going to be more use and changes in discharge patterns, either to home care or other types of facilities, because of infection control concerns in a congregate environment. And so do rehab facilities and home health become a partnership where a high-end rehab transitioning to home health becomes a more attractive alternative, or an alternative over a skilled nursing facility? Like I said, you can link to the article, take a read of it, but that certainly is a theory, if you will, being bandied about out there. So with that, I really appreciate your attention to the program. I hope you found it interesting. I am happy to answer questions at all that occur in a session that will occur set up for next week. And on the last slide, you have my contact information here. So please feel free to give me a call. I'm happy to discuss any issues you have, or talk to you if you want to learn more about the long-term care sector. Thank you.